Good morning and welcome to this YouTube channel of Pain-Free Partha, and welcome you all also to my website www.painfreepartha.com to download most of my slides. First of all, I wish to put my pranams, namaskars to Professor Ravi Shankar, who currently heads the Sea Dreams Director of Mahatma Gandhi Medical College and Research Institute, Pondicherry. So today we are going to talk about mitral stenosis, the pathophysiology, the base, the foundation of mitral stenosis, not detailing about its anesthetic implications. Now, what is it? Mitral stenosis is characterized by obstruction of the left ventricular inflow at the level of mitral valve due to the structural abnormality of the MV apparatus. So there is a mitral valve and there is a structural abnormality of the mitral valve. This causes obstruction and stenosis. The LV inflow is obstructed. This is what is the basics of mitral stenosis. The normal area is 4 to 6 square centimeters. Now, if the valve area goes below 2, it causes obstruction, creating a pressure gradient across the mitral valve. So normally, what is it? The valve is 4 to 6 square centimeters. If the valve area goes below 2, some people say it is 2.5, but 2 is okay. So the valve area is 4 to 6 square centimeters. Now, if the valve area goes below 2, it is mild. If it goes below 1.5, it is moderate. Goes below 1, it is severe. What happens here? The mean gradient is less than 5. What is the gradient between LV and LA? What is the difference in pressure in diastole? That is, what is the difference? The mean gradient goes up to 5 to 10. See here, pulmonary pressure is more than 50. So here, severe stenosis means less than 1 square centimeters. The mean gradient is more than 10. The mean and the pulmonary artery pressure is more than 50. These are all the problems when you say the mitral stenosis is severe. Now, what are the causes? The commonest cause is rheumatic fever. And slowly, after 1 or 2 years after an attack of rheumatic fever, the symptoms begin to come like, and usually becomes manifest at around 30 years in females. There may be calcium deposits. There may be other causes like radiation therapy, congenital, lupus, and other autoimmune conditions. So whenever you say mitral stenosis, my professor used to say there are 3 causes. 1 rheumatic, 2 rheumatic, 3 rheumatic. That is how our professor taught us. So there may be other causes of calcification, radiation therapy, congenital MS, lupus, and other immune conditions. Now, what is pressure gradient? Pressure gradient. Now you see LV. Systolic is 100 to 140. Diastolic is around 8. Here you can see in the diastole only. That is LV diastole. In the diastole only, the atrial systole happens. So it's around 8 or 9 or 10. What is the gradient now? The mean pressure gradient may be 1 or 2. Usually less than 5 in mild stenosis, 5 to 10 in moderate, more than 10 in severe. So it becomes 8, this becomes 28 or 25, then it becomes severe mitral stenosis. So this is what is the pressure gradient. Again, I am putting here mean pressure gradient is what is this mean like. Normally, almost all the blood flows from LA to LV in early diastole itself. So 85% goes almost. Atrial kick may contribute to 15%, maybe around that. So now here a mitral stenosis. It needs an atrial kick because here it is stenosed. Now again I will go. Mitral stenosis causes an increase in LA pressure. The normal is around 5. The pressure gradient may be up to 20 due to a severe mitral stenosis, which may cause a LA pressure to become 25. Now you see 6 becomes 25 here, and the mitral valve is stenosed. This is 5. Now what happens? Because this is 25, there is an increased pressure gradient which goes back as the pathophysiology. That is one part. The next part is the LA dilates. Because of the LA dilatation, there may be a chance of thrombus and there may be a chance of atrial fibrillation. So these are all the two problems. When you develop a pressure gradient slowly and you get a dilated left atrium, so it goes prompts for a thrombus and goes for an atrial fibrillation. Now the left atrial, this is what is about dilatation of the left atrium. The pressure can go transmitted to the pulmonary vasculature, go back again from the LA and cause pulmonary hypertension. Slowly the pulmonary artery direct hypertension goes into RV dysfunction. But here in mitral stenosis, usually LV is empty and spared. Now you see again, left atrial pressure is increased. The left atrium has increased in size. Now there is an increased size of LA, atrial fibrillation develops. That is the problem here. The atrial kick is lost in a fibrillating heart. So this is needed in mitral stenosis. Left ventricular filling also depends upon the atrial kick in severe mitral stenosis. So with the loss of the atrial kick, why this atrial kick has gone? Because of the atrial fibrillation. So patient goes into a development of CCF. It can add 15-20%, but this is not enough. It needs an increase in LAP. LAP has to increase. It has to develop a pressure gradient. It has to highly pressurize. That is why you need an increase in LAP and you need an increase in atrial systole. That is the kick to maintain the LV inflow and thereby the cardiac output. Now you see again, atrial contractility is gone, AF is gone, loss of atrial kick, irregular rhythm. This irregular rhythm may cause sometimes coronary blood flow as the problem. So this may cause LV dysfunction. As go back again, it may cause also RV dysfunction. So LV is usually empty and there is no problem with LV. If you want to be asked one question in examination, you tell LV is the spared in mitral stenosis, but it may have problems if there is an associated myocarditis. There is an associated rheumatic damage extending from the mitral valve apparatus into the heart, or an associated coronary artery disease. Now, we are told in one way. What is the one way? We are told the cause of the stenosis, LA pressure gradient is increasing, LA is dilating, it goes into fibrillation, the atrial kick is lost, may develop CCF. This is one part. I will go to the another part. Because of the increased pressure gradient, there is increased pulmonary pressure, venous. It goes on to go pulmonary arterial hypertension, which may cause RV dysfunction, slowly TR, and may cause increased SV. There the JVP may rise. So this has to be back from here. This is another pathophysiology. One part is LA dilatation, AF kick loss failure. Another part is back pressure is going through the venous, through the pulmonary artery to cause an RV hypertrophy, to cause a back tricuspid regurgitation, and measured as increased JVP. Now this is normal. You see, LA, LV aorta, 6 millimeters, pulmonary veins, this is 6. Again 20/8, RV is 20/5, LV is 120/5. So 6 liters flow is there from the LV to the aortic, through the aorta. Now you see there is a mitral stenosis where we have an orifice of around 1. Now you see here 120/5 is there, but you need an LA pressure to go up from 5 to 25 to maintain the 5-liter flow. And here from the pulmonary capillary pressure has gone to 25, pulmonary artery pressure has gone to 45. Here from 25 it has gone to 45.5. See here, but still there is no structural pulmonary vascular disease. All are functional. That's very important. So here this is a mitral stenosis. But here if you get a severe mitral stenosis, Sorry, this has to be here. Severe mitral stenosis, this goes to 3 liters. Now you see, LA has gone into 30 and this is 30. This is 30. RV you see almost like LV or more than LV, 130. And this is 20. You see, right atrial pressure. So this causes a pulmonary arterial hypertension with a structural damage. This we call it as second stenosis. Now, mitral stenosis obstruction, difficulty in LV filling, and decreased cardiac output. That may cause fatigue. That may cause exertional dyspnea because output is fixed. Increased LA pressure can cause LA function. Pulmonary venous pressure, slowly the compliance work of breathing is increased. Here you can see cardiac output is decreased. Severe PH can cause RV function dysfunction and tricuspid regurgitation. This is what I have told as secondary stenosis. Pulmonary vasodilators may increase RV output, thereby the LV output. So this causes increase means more from here to here. So it may cause LV output to increase. The hallmark of mitral stenosis is the doming of the anterior. See here, anterior mitral valve. This is cauda tympani. This is papillary muscle, anterolateral, posteromedial, posterior mitral leaflet, mitral annulus. This is the LA and this is the LV. What happens to the pressure volume loop? Cardiac pressure volume loop already I have put in a different video. Decrease in end diastolic, see here, decreased end diastolic volume. If this is decreased, end systolic volume is also decreased. End diastolic volume decreases more than end systolic volume. Stroke volume is also decreased if the curve is slightly pushed to the left. Not big change in the contractility. Contractility is okay. So that is what is the PV loop in mitral stenosis. Now we have what is the clinical symptoms. Now we know mitral stenosis, the causes, when it will get symptomatic, 4 to 6 centimeters, less than 2, less than 1, or less than 0.5 or something like that, which is mild, moderate, severe. What is the pathophysiology in 2 types? Now we will go to clinical symptomatology. Mitral stenosis presents as 20 to 40 years. You see, the patient gets rheumatic fever at the age of 6 and the patient presents with mitral stenosis at 26. This is what is important. The most common symptoms are dyspnea on exertion. Orthopnea. Orthopnea means dyspnea on lying down. Paroxysmal nocturnal dyspnea means during sleep, after 2 to 3 hours of good sleep, he gets up with dyspnea, goes to the windows, breathes for air, settles after some time and goes back. This is paroxysmal nocturnal dyspnea. Patients may have symptoms of palpitation, chest pain, hemoptysis, thromboembolism, ascites, edema, hepatomegaly. There is increase in symptoms of fatigue, weakness in exercise and pregnancy. Now we will go why all these symptoms should come in a patient with mitral stenosis. Now why should the patient be orthopnic? Orthopnea is caused by pulmonary congestion during lying down. If we lie down, pulmonary congestion is developing and there is a redistribution of blood volume from the lower extremities, splanchnic beds to the lungs. Normal patients with normal mitral valve, there is no effect because it can pump it out by the LV. But if it is going to be mitral stenosis, there is a reduction of vital capacity and the resultant shorten. So this is what is called orthopnea. Fixed cardiac output is there. So when the drugs, suddenly there is a, when you lie down, fluids come, blood comes, pulmonary congestion, patient gets dyspnea on lying down. This is what is called orthopnea. Why PND? He lies down, he gets in sleep. Why? Because he lies down, blood goes to the lungs. That will cause dyspnea. That is one. But in the night, what happens is already the respiratory center is dull. Already the adrenergic activity of the myocardium is less. So we are not ready to accept the challenge. Our heart in mitral stenosis is not ready to accept the additional problem of increased blood flow from there in a person where there is a respiratory drive is decreased, adrenergic drive is decreased. So that is why the problem of paroxysmal nocturnal dyspnea comes. Orthopnea comes because blood from the vessels and splanchnic goes to the lungs. Same thing can happen here, but in the setting of decreased respiratory drive and decreased myocardial sympathetic activity. Why wheezing? Bronchospasm is associated with pulmonary congestion, edema of the bronchial walls that can stimulate the local receptors and cause wheezing. That is why in some patients with bronchial mitral stenosis with pulmonary edema, sometimes a nebulization may be effective. So cough is always there in patients with mild pulmonary edema. Wheezing, I have already told. Dyspnea on exertion is a classical symptom of pulmonary edema. Orthopnea, PND. Chest pain can occur because of the pulmonary hypertension and stretch. RV failure because of the back pressure, and there is an RV hypertrophy, goes into failure. Palpitation is because of the atrial fibrillation and this thing. The left atrium can enlarge and press on the lateral laryngeal nerve to cause hoarseness. Because of the pulmonary hypertension, there are small aneurysms. They called it as Rasmussen's aneurysms. Sometimes they may rupture and give out to hemoptysis. Fatigue, because here it's a forward problem. All these were backward problems. Now you have a forward problem. What is a forward problem? LV is not pumping out much. Because there is a mitral stenosis, LV is not pumping out much. So we get fatigue. So these are all the symptoms and reasons for patients in mitral stenosis. What are the clinical findings? Now we have clearly told what are the symptoms and why should they occur. Now what are the findings and why should they occur? There is a low pulse because it's a fixed cardiac output, low output state. Mitral stenosis, nothing is coming to the LV. Irregular pulse. Edema, already we know there may be an RV failure. Because of the irregular pulse, and there may be a pulse deficit. We don't know, because of embolism, there are all pulses are felt or not. There may be mitral phases. There may be a palpable P2 because of pulmonary hypertension. There may be a diastolic thrill. There may be a tapping apical impulse. These are all the clinical signs. First heart sound is loud and may be palpable. This is what is called the tapping beat because of the increased force in the closure of the mitral valve. Tapping apical impulse. What is mitral feces? This is red and this is blue. Malar, flush and lip cyanosis. This is what is called mitral feces. I'm telling it is very difficult to find out in Indians, but here it is very clear. With all the findings, now why should be the reason? Low pulse, why irregular pulse, why should there be a pulse deficit, why should there be an edema, why should there be an increased JVP, peripheral edema, all been reasoned out. Now I will go to auscultation. The first heart sound is usually loud, maybe palpable. There is an increased force in closing the mitral valve. That is why it causes loud S1. The pulmonary component of the S2. Now S2 has got A2 and P2. But P2 is loud here because pulmonary hypertension. P2 is loud. S1 is loud. P2 is loud. An opening snap is an additional sound where it will occur after the second heart sound. Forceful opening because it is stiff valve. It forcefully opens. So it causes an opening snap. So a mid-diastolic rumbling murmur. Stenosed valve. Usually we used to say when the murmur will come. A murmur will come when the normal flow through an abnormal valve or an abnormal flow through a normal valve. Now what is here? Abnormal valve, normal flow. So stenosed valve, murmur will occur and this is low pitched, but sometimes this pre-systolic accentuation may not be there in atrial fibrillation. It is best heard with the bell of the stethoscope because it's a low pitched. Accentuates in left lateral position with some exercise. S1 is loud, This P2 is loud, P2 is followed by a blue opening snap, and this is diastole, a mid-diastolic murmur, a pre-systolic accentuation, which again starts in loud S1. These are all the clinical findings. Now you see S2. This S2 is P2. P2 is loud, followed by opening snap, followed by some early free diastole, then mid-diastolic murmur, pre-systolic accentuation, ending with a loud S1. This is what is the classical cardiac findings of mitral stenosis. Respiratory system may have pulmonary edema features. JVP, ascites, hepatomegaly are relatively rare, and signs of other embolisms may be there. Now we have found out what are the things like in mitral stenosis. ECG, yes. Atrial fibrillation, it may show. Left atrial dilatation of P mitral, it may show. RVH, it may show. These are all the three things. Left atrial dilatation, P mitral will come in V1. V1 P mitral, bifid P wave, okay, or a biphasic P wave. Atrial fibrillation, we know irregularly fibrillatory waves. There may be RVH. What is this RVH? We can go to ECG made easy by me. RVH is in V1 you see a big R wave. So X-ray will show straightening of the left border. Echo is obviously, you should know mitral valve orifice. You should confirm the diagnosis. Then you should know what is the anatomy of the mitral valve. Then you should know whether there is any thrombus and there is any regurgitation, any calcium deposits. All these things you should know by way of echo. The analysis of morphology of a valve includes all these things are needed. And there are scoring systems like Wilkins score and Padial scoring. And to diagnose, cardiac catheterization is the last resort to diagnose. Now left atrial enlargement in V2 it will be like this, bifid, and this is biphasic P wave. This is left atrial, more than 2 squares. There may be a thickening of the bronchial fissure. You see here the left atrial dilatation. Here there must be a pulmonary bay. This is gone. So the aortic knuckle comes. The bay is gone. That is why the heart straightens. Medical therapy is focused on preventing endocarditis. Now what we know the symptoms, we know the etiology, we know the clinical findings, and we know how to diagnose. ECG, X-ray chest, and echo. These are all basic things. What then is the management? Management is preventing endocarditis, new cases of rheumatic, improving symptoms, and thromboembolic risk. Actually, no drug will open the valve. Valve is not open. We are going to prevent your rheumatic fever. You are going to prevent the thromboembolic risk. We are going to decrease the failure. All these things we can do, but the drugs cannot open the valve. Now, what is the cardiac grid? When we say mitral stenosis, aortic regurgitation, ventricular septal defect, any cardiac disease, we should know the cardiac grid. Means what is in each preload, systemic vascular resistance, heart rate, contractility, PVR, what is ideal for mitral stenosis. This is what is called the cardiac grid. Now you know preload. It may be slightly increased or it should not come down drastically. Now you see there is a fixed cardiac output. If you have a preload reduction, for example, the patient hits into this thing and bleeds some 750 ml. So fixed cardiac output preload is decreased. The patient will become bad. There is no output. So decreased in preload is not ideal. Pulmonary pressures are high. So aim for volumia. Keeping in mind the fluid boluses can worsen edema. We can give some fluid boluses, keeping in mind what will happen to the pulmonary vasculature and back pressure causing edema. But preload reduction is dangerous. Now pulmonary pressures are high. This is the LV, this is the aorta going back. Now if you give IV fluids here, we are giving to the vena cava. It will come to the RA and it will come to the RV and pulmonary pressures. It will go to the lungs. And yes, here we need to be cautious whether it is going to the lungs in excess. Otherwise, if it is going to the pulmonary vein and pushing more in the event of mitral stenosis and pushing more of the output, then it is okay. If that is the problem, when you give this, then stop and decrease. So preload may slightly increase or it may be normal. Any reduction in preload is catastrophic. Less preload, cardiac output is already less with stenotic lesions. Prefer a little excess than a complete stoppage. So fixed cardiac output, prefer a little excess. Now what is the afterload? Already we know what is afterload. Okay, because the cycle is running down the mountain. Afterload reduction means cycle is easy to maintain the running down. Afterload is increase means we have cycling up the mountain. Because the cardiac output is fixed, any reduction in SVR can cause a decrease in CPR, coronary perfusion pressures. Now you see, there is a mitral stenosis. LV is pushing. This is green is fine. If you increase this afterload, if you increase the afterload, now you see these are the coronary vessels. And this may get problematic if there is any reduction in SVR, decrease in coronary pressures. So we have to be careful whether there is an ideal pressure by maintaining an ideal afterload. Yes, we have to be very careful because if you give a drug which causes afterload reduction, it will also cause some preload reduction. So don't go very just think about afterload reduction or increase in afterload. All these things may act also on the veins, and this may cause also venodilatation and decreased preload. Cardiac output into mitral valve area into root of pressure gradient is Garlin's formula. This is there. So what I want to say is, if the mitral cardiac output has to increase in a fixed mitral valve area, the pressure gradient has to square. The pressure gradient has to square in a fixed mitral valve if the cardiac output is going to increase. Okay. If this is fixed, then your heart rate, SEP, all these things will be mattering. And the heart rate also will decrease your diastolic time. Filling is decreased, so pressure gradient may increase. And if the rate is below 60, heart rate into SV is cardiac output, everything will decrease. So that is why we have to maintain the heart rate above 60 and we should not cause tachycardia like 90, 95. So this is one cardiac rate. Now we know about the preload, that it cannot be decreased, slightly increased or flat. And afterload reduction is compromising coronary blood flow. Heart rate has to be kept around 70 because low cardiac output means the SV is fixed, stroke volume is fixed. The cardiac output will decrease because heart rate into SV is same. If you go high, 100, 95, tachycardia will decrease diastolic time. The pressure gradient may increase by square or something like that. So this may cause back pressure edema. The flow is less, the pressure gradient increases, causing back pressure edema. Now we have told about other things. Now we get into pulmonary vascular pressures should be optimized. There should not be hypoxia. There should not be hypercapnia. There should not be acidosis. All these things may increase PVR and your RV dysfunction will come. Nitrous oxide is not ideal because it may cause increased PVR. So we should not cause increased PVR. PVR should be normal or slightly decreased. This is form the cardiac grid in managing a patient with mitral stenosis. Hypoxia, hypercarbia, acidosis, no. Nitrous oxide, preferably no. Already the PVR is high. Now, what is about contractility? So, again, you see mitral stenosis, aorta is coming, again, pulmonary vena. So, maintain no myocardial depression, don't depress the heart. Do we need to give inotropes because LV is okay and LV inflow is pushing out? So inotropes may not help much. But if there is an RV dysfunction, we can go for NORAD or milrinone, which will not cause SVR problems. Which will not cause SVR problems. So all these things are important. We need to treat this RV if there is a contractility problem. If you are going for this thing. No dobutamine because suddenly it will decrease the SVR. So in these patients, if you are planning RV dysfunction is a problem, prefer NORAD or milrinone. See the muscle mass. That is why RV is likely. LV is see the muscle mass. See the muscle mass of RV. So even RV hypertrophy comes. It's likely to fail. Now what determines LV filling? You think the preload. Yes. Preload is a determinant. How much volume is there? If you give a diaphragm or whatever it is. The length of diastole. The diastole heart rate is increased. Diastole is decreased. Filling is decreased. Pressure gradient becomes the LA and LV. So pressure gradient is 25 by 5, it will fill. If there is no atrial fibrillation, systole is fine, it will fill. The valve area, mitral valve area, if it is 2.5 square centimeters, yes, easily fill. One, no. So the length of the diastole, the pressure gradient, the mitral valve area, the atrial systole, all determines what is needed for LV to fill and push out into the aorta to get a good cardiac output. So preload, neutral or slightly increased. Heart rate is around preferably 70. SVR, don't decrease. PVR, no increase. Contractility, LV is not going to matter. If there is an RV dysfunction, use NORAD or milrinone. Now, what are the bad signs of mitral stenosis? If there is a patient with new NYHA4, parallaxis 1 nocturnal dyspnea, severe orthopnea, if your mitral valve area is less than 1 square centimeters, if the patient is atrial fibrillation and rapid ventricular rate, if your systolic PA is more than 50, all these matter. You think that these are all bad signs of mitral stenosis. What are the drugs they use? They use digoxin, they use diltiazem, beta blockers. They use diuretics for failure. They use warfarin for prevention of embolism. They use penicillin for prevention of rheumatic fever. These are all the common drugs they use in patients with mitral stenosis. Now we go to anesthesia and finish within 1.5 minutes. Okay? Understand the severity. That is very important. If there is an RV failure, the severity is more. If the pulmonary systolic pressure is more than 50, severity is more. If your stenosed valve is only 0.5 square centimeters, severe. Your pressure gradient is 25, severe. Understand the severity. Understand the drugs we are using. Sometimes we were using warfarin. Sometimes we were using digoxin and diuretics. Diuretics may cause hypokalemia. Hypokalemia setting the digoxin can cause arrhythmias. Your diuretics may cause volume depletion, decrease the preload. Understand the drugs. Warfarin you should need to stop and switch over. All these things you should understand. What are the drugs you are using? What are the coexisting conditions? For example, all things pathophysiology will change if you have an MS with AR, MS with MR, MS with AS, all these things. Whatever I have told so far is clearly an MS predominance. Understand the coexisting conditions and maintain the cardiac grid. What is the grid? Preload should not be decreased. Contractility is not a problem when there is. Heart rate is around 70. Don't decrease the SVR. Don't increase the PVR. These are all the cardiac grid we need to maintain in anesthesia. Anesthesia, yes, fine. Blocks are fine. If you are putting a brachial plexus block, no heart rate change, but think of adrenaline. Very important. If you have given any vascular slightly gone, adrenaline heart rate increases, that may be a problem. Otherwise, blocks are fine. Neuraxial. What is neuraxial? If you give spinal, what happens? Preload decreases, heart rate changes. You have to idealize. In general anesthesia, the induction should be smooth. We may go for etamidate. We may go for a smooth intubation to give drugs. You should be pain free because pain is increasing your heart rate and causing so much problem. You may have a smooth extubation and your post-operative period will be smooth in terms of maintaining the cardiac rate. Most of these things which I have told is for a patient with mitral stenosis coming for a non-cardiac surgeries. Mitral stenosis coming for MVR is slightly separate, even though the basics of maintaining the cardiac grid remain similar even in your mitral valve operations. Maintain the grid. Whatever anesthesia you give, I will maintain the grid. I will give the spinal anesthesia like this so that the preload doesn't decrease. I will add fentanyl. Whatever you do, you maintain the grid. Heart rate is 70. SVR doesn't decrease. PVR doesn't increase. Contractility is maintained. All these things, maintain the grid. So thank you all for your cooperation. Visit me at YouTube, Pain Free Partha, and my slides are Pain Free.